Hello, everybody, and welcome to Pain Geeks. We're here for another discussion, and this time we're going to be discussing causation and the clinic and pain and all those things that we're super interested in. So we're delighted to be able to welcome philosopher Rani Anjum today, who's going to talk to us a little bit about her project called the Cause Health Project, which we will put links to, and you can go and check that out if you haven't already, although I'm assuming lots of you are already interested in that and have been reading that chapter. And today we're specifically focusing on chapter 2 in the Cause Health book. So yeah, let's go around and introduce everybody. So Rani, would you like to introduce yourself to everybody?
Yeah, thank you for inviting me. I am a philosopher at the Norwegian University of Life Sciences, so obviously in Norway. And well, the Cause Health project started in 2015, so it's called Causation, Complexity, and Evidence in Health Sciences. So, and then it just continued. So Elena Rocca, my colleague, she got a 3-year grant to continue, and well, here we are. So the official end was actually on 1st of October. So now we're just rolling. We're just rolling on.
I don't think it will. I don't think it will ever end for us as clinicians. Anyway, I think like it's definitely become a staple within our conversations, especially around pain. Okay, so lovely opportunity now to introduce the Pain Geeks team as well. So my name is Laura Rathbone. I'm a physiotherapist interested in pain and all things that come along with that. And I would like to introduce the rest of our Pain Geeks team. So, Christine, over to you.
Hello, I'm Christine, also a physiotherapist interested in pain. And I started working on the Pain Geeks team back in, I always get this wrong, but I think it was May. I think.
Yeah, whatever month you say, it was probably the month before.
Yeah, really not sure. But anyways, it's been great so far. And I've really enjoyed the process of, yeah, having accountability also to read more and to, get engaged in interesting discussions and a lot of the things that I was missing in my clinical life. So it's been a great addition to that.
Yeah, it's been brilliant having you as well and taking our really like all the excellent cool stuff you see on Instagram is all Christine. So she's like okay, and Nikita, our newest member.
Hey, hi everyone. I'm Nikita Mascarenas. I'm an MSK physio. As you can see, very interested in pain, which is why I'm here. Not as experienced, but have this thirst for knowledge. So I'm glad I found a home, and very grateful to Laura and Christine for starting this, and to you, Rani, for giving us your time, because we have a lot of questions.
Wonderful. So, yeah, well, let's get started. So, shall we start by just giving a bit of an outline to the chapter? Rani, would you like to just do that, or shall we start with some questions? This is super informal as always and completely unorganized on my part, but yeah, shall we make it start?
Well, I could say something about the chapter because it is the first official chapter of the book. So before that, it's just the introduction. And so the book is Rethinking Causality, Complexity, and Evidence for the Unique Patient. So we wanted to start with telling people where do we come from. So the first part of the book is spelling out the theory. And this chapter is introducing the concept of dispositions, because it's always something that people get a bit, dispositionalism, how do I even say it? So we wanted to explain why we are interested in the uniqueness, and how that contrasts with the way that science, any type of research on causation is normally approached. Because typically we think that if you want to understand causation, you start by looking for regularities. So maybe you start with lots of statistical data and then you see patterns of regularities, and then you wonder, are any of these causal? And then to even get to the patterns of regularity, you need to have a lot of people having exactly the same. And then we say, well, here's the problem. It's that we know that everyone is different. Even if we are purely reductionist and we think that everyone is just biology anyway, we all have different genes. And even if you have different genes, I mean, everything that you do in your life is going to affect your immune system, affect your development. So it's not going to be straightforward to look for something same. So what we're trying to say is that, well, if you look at what is sufficiently similar, yeah, that's how we get our diagnosis. It's how we understand about mechanisms, causal mechanisms, how things work. But it seems that we are missing out on a lot of knowledge that we could actually gather from learning about the uniqueness and the marginals and the outliers. So all these limit cases where you don't get the expected outcome with same. So then we say that, well, there is an understanding of causation that can deal with this kind of uniqueness, and that's what we call this dispositionalism about causation. So that's like the starting point for this, and trying to spell out what does it mean. So for instance, causation is always complex. It's always an interaction between what you do to someone and what is already there. It's looking at the properties, and some of these properties are not directly observable. So this is what the chapter is trying to explain. And then we try to quote some practitioners who say that, well, this uniqueness and the way that they get to the uniqueness of the patient is through the patient stories. Okay, so I hope that was introduction enough.
Yeah, definitely. And, you know, it makes so much sense to us from a pain perspective, because everything that we have now, all the sort of old models and the old understanding of mechanisms and causality are failing us on the clinic floor, right? And we feel that, and the conflict and the discomfort that happens between the clinician and the patient is in that desperately trying to solve, why is this understanding failing? And it's either because something is happening in the patient that we can't see, or there's something happening in us and we're not good enough. And then it just creates this cycle of breakdown between clinician and patient over and over again, when actually the truth, if we can call it that, is probably all there within the setting. We just don't have the skills to look wider than this sort of like monocausality that we've been taught.
Yeah, I was just going to say, I think, and it's also like a fine line as a clinician too, because one of the things that you had mentioned in one of the podcasts I was listening to you, Rani, was about how, you know, when we listen to patient narratives, people will tell us what the side effects are of certain drugs or treatments that they're having, but you know, we tend maybe to not accept that as something that's plausible because maybe we've never heard it somewhere else, or it's not showing up in the research. And that's a really difficult line for clinicians, I think, in general, because you have this person telling you this information and they are making links. And then you're sitting there thinking, okay, well, is that plausible? Is that not plausible? And is it also something that is validated by other people's experiences or things that the research has said? And I find that that's a pretty precarious, difficult position to be in. That's all.
Yeah, it is really difficult because everything that we are taught about causation is that no way can I trust what they say here unless there's evidence from other people that this thing could happen. But the point is, if anyone is in a clinical study, then you listen to them. So why would you listen to them there, what they report is happening to them, but you wouldn't listen to them when they're just sat in front of you? To me, this is, I mean, because we accept something as causal evidence in one situation where it's compared and it's analyzed and blah, 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 but we don't accept exactly the same thing when they're sat in front of us. But the thing is that causal evidence is collected sometimes in research, but very often it's what we experience all the time. So I don't like that this is dismissed and only what is happening to people who met the inclusion-exclusion criteria in a study, that they are heard, because they might not even be representative.
Yeah, which takes us back to a previous theme we've looked at when we've been looking at some of the work by Javi Carrel on epistemological privileging and injustice. You know, which person's knowledge are we privileging in the clinic, and when we over privilege perhaps previous scientific knowledge or previous clinical knowledge, and we deprivilege or down privilege the information coming from the patient, we create this huge, we're missing probably the causally relevant information for that individual, which I think is what you really say very clearly in this chapter, that all the causally relevant information is coming out in that individual.
Mm-hmm. Do you maybe want to talk a little bit about what dispositions are and how they relate to causation?
Yeah, so dispositional properties, they are properties that can exist even if they haven't manifest themselves in something observable. So we say, for instance, that something is explosive or something is flammable or something is fragile, but it doesn't mean that it has exploded or burst into flame or broken yet. So these types of properties, they are problematic from what we call an empiricist perspective, where you only accept as knowledge what you can observe. And when we think of causation, then all of the theories of causation that have been available out there, they have started with the assumption that you have the cause and the effect. And then your question is whether there is or is not an invisible link between them. So all of your understanding of the causal link will be derived from caring about the things that you can observe, the cause and effect. But sometimes you cannot actually observe the effect from a dispositionalist perspective, because if you, for instance, think that, so now it's quite warm in this room and I have a heater and it's really good. So if I turn it on full, it can warm the room to maybe 28 degrees. So I switch it on full. But then if I'm surprised why it's still like 10 degrees, well, maybe it turns out that the door is open. So the front door is open, it's really cold outside. So if I'm only going to go by what I can observe, I would say that, well, I turn the heating on full, but the room is only 10 degrees, so it doesn't work. I mean, that's what I have to conclude. But that's not really true, because the oven is doing all the work it can. I mean, it's really working, but there are other things counteracting it so that it doesn't get to manifest what it was supposed to manifest. So I think that's also the case in a lot of treatments, that we know that this treatment has a disposition to help you, but there are so many other things counteracting that. Okay, so maybe it's doing something, it's you're working really hard, but you need to care about these other things first. So should you lock the door? Should you close the door? Should you introduce a second heater? Maybe turn off the air conditioner? I mean, there's lots of things that you should worry about. So if we only focus on this one thing and this observable outcome, we might a lot of the time be mistaken about that. We think nothing is going on. So for instance, if we look at side effects of treatments, of medical treatments, because we all trust medicines a lot, but they also know that it takes many years before you start seeing the side effects of medications. So you have to monitor them for a long time. And there has been some medications where it turns out that if pregnant women take them, then when their daughters are 30, they might get vaginal cancer. So it's like because their uterus wasn't properly developed and things weren't developed properly while they were fetuses. So I mean, how on earth would we even know that? So if you only look at the intervention and the immediate change in the outcome, you're not really seeing all of the causal information that you need. So I think this temporal aspect of causation, that there's a lot of things going on, it's a process. So that might also mean that if you're working with someone and they're doing exercises or they're doing various things, well, things might actually be happening. They might be preparing the situation for that something can happen. So it doesn't mean that nothing is going on. So that's why I'm thinking we have to look at what else is already there counteracting. Well, maybe this wasn't the right manifestation partner for that. I mean, maybe the oven was too small for the house. That might be the case. You don't know, but at least it's something that we should have our focus on.
Right. Yeah. So, I just also want to say that I really enjoyed reading this chapter and listening to some of your podcasts and YouTube videos, because I find you use really great examples, and they're super helpful.
Oh,
and
thank you.
I really like them. And so what I understand, right, is that what you're trying to say is that, you know, causation is actually sort of the maybe the outcome of multiple dispositions or properties interacting with each other, and that we need to be sort of broadening our perspectives and paying attention to sort of all of the relationships between all of the dispositions that are happening sort of simultaneously. And how would you suggest, like, how would we go about researching that? How would we go about like learning what that is? Because what I'm thinking in my mind is, okay, if we're saying that the cause is happening because of multiple interactions happening at the same time, this is maybe my reductionist mind, but then how do we know what is the cause of what, and what are we, you know what I mean?
Yeah, and that has been, I mean, since the experimental method was introduced, long time ago, that has been a problem, because we have assumed that if you want to understand the complex phenomenon, you need to start by looking at each thing individually and separately. And how do you even separate? I mean, if you, how do you isolate and separate? The problem is, even if you want to understand the cause of a match lighting, and you strike it and it lights, and you're thinking, oh my God, yes, so the striking is definitely the cause. But I mean, we know that you need to have a flammable tip, the wood that burns, you need the oxygen, you need a lot of things. So to say that only one of them could alone cause the effect is just wrong. So that's a problem. It's almost like, so I often use the example with the pill. So we think that the pill has a curative effect or a curative disposition. But if you put it on the table, it's not going to cure anything. So once you give it to someone and you think, oh my God, the pill did it, but it could only do something because it was in the right context. It had to interact with something that was able to, well, digest it and maybe have the right receptors. You need to do a lot of things. So I think that this kind of isolation and separation, it has been really important for a certain concept of causation, which is that the cause is something that makes a difference to the effect. And the problem is that if you try to check three things, you're thinking, oh no, I don't know which of them is causally responsible. But if you say, no, actually, you need all of those things, then why would you even try to separate them? So that's why we talk about mutual manifestation partners instead. It's when different dispositions come together and they can do something. So what you need to know is whether you have the right manifestation partners. So if you just do the same thing and expect the same effect, you have to know that the manifestation partner is appropriate. So you might actually be harming your patient if they're not a right manifestation partner, or you might not even get to do the treatment. If you say, well, you should do these and these exercises, but they have they cannot even do the exercise, then of course, obviously that's not the right intervention. So this is stuff, it's a lot of stuff that that you wouldn't even think of investigating. So it just shows how much know-how we all have. And the person who comes to you, they will have a lot of understanding about their own body. Because so when Elena was working with Uppsala Monitoring Center for Drug Safety, they have all these clinical reports from patients directly, or from their clinicians reporting on side effects. And sometimes they look at the reports and they see, but this person is taking 10 medications. How do they know it's this thing? But they haven't asked in the they haven't asked in the questionnaire, because what they ask is very typical stuff that they need for a more statistical analysis. So not Uppsala Monitoring Center, they have quite good stuff. But one thing they say is that I wish we could ask them, why do you think it's this particular thing? So it might be, I've been using all this other thing and this was the thing that changed. But that's really useful to know. So I think a lot of the time when you have the patient narrative, for statistical purposes, we think that's noise. But for the clinical context, it might be really useful information that you get.
So what would this research be? What would this look like? How would it be different than like sort of the typical RCTs that we do now? Would it just be more case studies or that kind of stuff?
Yeah, so this is something we say in the conclusion of the book. So we have 10 recommendations or 11 recommendations. And one of them is to, for instance, look at marginal and outlier cases, because you learn about things that could happen if you have the right or the wrong manifestation partner. So, for instance, if something is very rare, if a person has a very rare set of dispositions, for instance, or there's something in their context that is very rare, you can actually learn more about the mechanisms and what that treatment can do. So what we are saying is that you need to understand a mechanism in the sense that it's quite complex, because you don't only want to know that, okay, when we do this, then this happens because of a mechanism in between. We want to say, okay, when you do this, then that tends to happen unless this, this, and this, and if it interacts with such, and such, but these things are causally relevant, these things are necessary, these things are, so it's a lot of things you need to know. So once you have information from an RCT, for instance, that this makes a statistical difference in the tested population, then that cannot be the end of the story from a dispositionalist perspective. That has to be a starting point, and then we need to start trying to understand why and how these things are working. So Elena and I, we did we wrote a paper where we tried to explain how you need many different methodological approaches working in combination to understand these intrinsic dispositions. But one of the things that is really important there is qualitative research. It's something that you cannot do without.
Yeah, I really liked your the example you used of like the light switch, and how if we're always just looking at the light switch and then the light is turning on and we do that 100 times, we would probably conclude that that's why the light goes on. But then the one time when it doesn't, then you start to realize all the other reasons why that might not be working. I thought that was a great example.
Yeah, thanks. Because that's the point. If we just keep counting and counting, and we're very, very happy with our research, but we have learned nothing about causation.
Yeah.
I think that's the really frightening direction of research.
Yeah.
I think it's interesting. So just before we came on, you said one of the main sort of driving factors behind people getting interested in cause health was pain. And I'm just constantly thinking about, we for years we have said, and for generations, and still saying, the idea of the slip disc is the cause of back pain or neuropathic pain. And then what we find is, well, actually, when we start looking at, because we were looking for that answer in the scientific evidence, weren't we? We were trying to find, does this repeat because it was seen in anatomy? So then it was, well, does this repeat in everybody that gets back? So we were only looking at people with back pain, and then we were seeing these disc prolapses, and then that was the proof almost that this is happening. And then the more we started looking at using the scientific knowledge that we had and the ability to observe changed, the more we started to realize, well, actually, maybe this is just for many people, a normal phenomena, biological event that is just happening within their anatomy, and it's not necessarily always associated with the symptom. And so the cause and effect relationship started to disappear as our scientific technology and our ability to observe improved. And I don't know if I'm taking us to another place, so I apologize, but I was reading all this and listening to you, and I was thinking, if Hume were alive today, would he be a fan of complexity? If he had access, because I mean, we have to read Hume in the context of his era, right? It's like when you read Descartes, you have to read it in the context of that era, the scientific knowledge that they had, the models they were working on, the cultural references around them, religion, all, like, who was the socio-political control, all of that at the same time. And I just wonder, if Hume had access to all of the stuff we have now, do you think he would walk back? Because, you know, using a like, for example, the billiard ball analogy, that's one that you say that in the chapter that Hume used. I mean, that makes sense in a way, because that's what they were observing, and that's probably relevant to the scientific culture at the time. But if he were alive today, would he update, do you think? Don't know.
No, but there are a lot of Humeans alive today.
Yeah,
and,
but
and one thing that they would say is that, well, that they actually also say is that if you analyze complexity and you look at all these dispositions that are unique and such and such, the whole point is that if there was exactly the same thing happening again, the same effect would happen. So if there was the possibility, if it was real causation, it just means that the same cause should give same effect under the same conditions. So any type of complexity that you would see, okay, so all of these things are needed to get this and this, yes, okay, so every time you see it, you should get exactly this. So what people would normally then do is to say that, okay, they make themselves a mental model where you have all these factors. Okay, so now I have a unique person in front of me and this happened to them. Okay, if I had exactly this type of person in front of me again, then this thing would definitely happen to them as well. And if something else happened, it means that there was a difference that was causally relevant. So you keep thinking in this kind of twin population. So all you can really know, and this is because of the empiricist starting point that you can only know what you can observe. So we try to challenge that. So Stephen Mumford and I, when we introduced this theory, we said there's nothing in principle wrong with observing causation, because we keep thinking that you have a cause over here and then nothing, and then eventually you observe an effect over there. But we can actually, in many situations, we can experience causation because it's a change of property that happens within the same individual, for instance. So you can notice if you get hotter, or if someone is trying to push you and you lose your balance, but then you manage to get it back. We say that you can experience causation in your own body. Of course, Hume wouldn't accept that, because he would just say, oh, it's just that you, whenever someone is pushing you and you try to, and then you manage to, it's just like a series of events. So it's like a series of regularity. But we're saying that not actually this kind of continuous process of change is something that we can observe. So we can even look at a tomato lying in the window, going from green to red. So it's something that you can see over time. But of course, the problem that Hume had and that many people have today is that data are observable and theories of explanations are not observable. So they are speculative, and Hume said, burn those books. But what we're saying is that, no, you cannot do without the theoretical speculation. So science cannot do only with data.
Because then you would say, like, the tomato turned red because it was sitting on the windowsill, or just because it was sitting on something. You know, you could say that because that's what you see, but that wouldn't necessarily be the reason why it turned red.
So that's why empiricists, scientists, and researchers are really skeptical of theories, because you can always get it wrong. But then if you don't have the theory, then you're stuck with the light switch. I mean, what you can do from a human perspective is, of course, that you see that, okay, every time you switch it, it lights. But then if the light bulb is black, then it would never. Or if the wire is chewed off, then it would never. So you can still experience a lot of these regularities, but he wouldn't like them to be explained by dispositions that this thing can do this and this, because he would say the only reason why you think so is that you have seen this manifesting itself in the past. You think that the glass is fragile because you have seen glasses break. Without it, you don't know that this glass is fragile. You just assume. And a lot of scientists, I mean, they would say that you can observe, for instance, fragility. You can observe that someone is fertile. So you can do a test where you get an observable thing where you can know that you have a disposition. So a lot of people who are empiricists would try to reduce dispositions to something that you could tease out to manifest itself in some way without manifesting properly. So you can know about an avalanche, danger of avalanche, for instance, before it starts, because there's something structural in the snow layers.
Well, then wouldn't weather predictions be better if that was true? Like, they might get the weather forecast right if that was true, right? Yeah, surely. But what you're saying there is that we're still giving causal privilege then to one particular process or one particular mechanism. So we're saying, like, we're still taking that idea of, well, we're turning the light off. Oh, but then there must be this process that isn't happening, must be, and therefore that is the causally relevant information, and we're disregarding the wider context and the wider complexity, which might all be interacting.
Well, there seems to be this expectation that there needs to be this one-to-one relationship between cause and effect. So, for instance, if we want to understand autism, some people have said there should be something in the brain that you can observe that everyone with autism has, and everyone who doesn't have autism doesn't have it. Mm-hmm. And that's problematic if we try to reduce all phenomena like that, because sometimes the relevant disposition might not be exactly what you're looking at. So I used the example in the past with when you have a vending machine and it needs a coin. And because you want to buy something. So you need a coin, and that coin has various dispositions. For instance, it's valuable because it's worth something, and that's why you can buy with it. But sometimes if you're on a train or something, they give you a little token that you can use, and it has no value. It only has value in that vending machine because you can get this thing. So the relevant dispositional properties there is the shape. Mm-hmm. It's the shape and maybe the weight, because it needs to go down in the right thing. But if you go to the shop, it's not going to have the relevant disposition. So what is relevant? But then you can have a credit card, or you can use an app, or you can use another things that doesn't look at all like this thing. So that's why I'm also thinking the striking of the match to get it to light. Well, that's not the only way to get the match to light. Sometimes you can take one match and light another match, or light it with a candle, or on some other rough surface. So why do we think that there has to be this one-to-one relationship? I think that's really mistaking, or this is a concept of causation, that it's a necessary condition for the effect. If it hadn't been for this should never have happened. Mm-hmm. And that's why we also dismiss, for instance, every time someone gets better without the medication, because we think, well, surely they shouldn't get better without the medication. That must be a placebo or something. But we know that the body can heal itself. I mean, otherwise we would never survive. But people still think that's kind of bullshit. Yeah. Why on earth would you get better if you didn't get the proper drug? So
pain is a disposition in a way. So to pain and to heal, or to self-heal, I guess, is also dispositions that exist within all of us. And
yeah, and there are many ways to pain. I mean, you can have the same pain that got there in so many different ways. I mean, sometimes if I get stressed, suddenly I feel something here, and I'm like, why would I feel something there? Just like, oh shit. But just because I keep thinking about something like, oh, a deadline, or shit, did I miss that meeting? But I mean, I know there wasn't something inside of there that was bad, but so surely this headaches, this pain in the shoulder and neck, I mean, they can come from different things. So they're manifestations of many different types of dispositions in different people. So why do we keep thinking that it has to be the same thing in everyone for it to count as relevant pain, or actually caused pain, or something that you can believe in?
Yeah, I can see how we've got here from that sort of Cartesian modeling of healthcare, reductionism, through the empiricism and positivism and frequentist privileging of science, and then I can see why we're here. But yeah, I think we've reached that point now where it no longer makes sense for what we're doing, and we're struggling with that. One of the interesting things that, and this is why the vector model which you introduce in this chapter and then go on further, but you know, it's an interesting way of mapping dispositions within an individual versus trying to get to the specific, like what is the thing that is the most causally relevant, one thing that is happening in this person. Do you want to just chat through a little bit more about that? Is that okay?
I think through the vector model,
Yeah,
I could do that. Maybe I should try to show a picture of the vector model.
well, we can put that on the we can.
I was just gonna do this.
Oh
yeah, do that.
That's a good
Exactly. So consider one of those vectors, maybe the really long one, towards G. Consider that one your heater, or my heater, which is really strong. And then the opposite vector that goes in the opposite direction is the open door, and it's really cold outside. So then you see, yeah, you can add more heaters, or you can take away the open the draft from the open door, and you see how that would change the overall situation, which is the lower thicker arrow there. So whether or not you actually get to the threshold effect is going to depend not only on what is disposing towards the effect, but it's going to depend on what is counteracting it. And that's why we say, okay, so you can add something or you can remove something. So one of the ideas behind this vector model is when you're in the shower and you think the water is too cold. So you can add more hot water, or you can remove some of the cold water. So that would be like additive or subtractive interference to get the outcome that you want. So this kind of, so even that case is not very complex. It's only these two things, but you still have two options. So maybe you couldn't, maybe you had the hot on maximum, so you couldn't actually take more hot water. Then you have to remove some cold water. So that's why you have to think, okay, what can I change and what can I not change? Because there's always something you cannot do something about. But usually there is something you can do something about. Even if it's not already there, you can add something new.
There's this kind of, and maybe I've got this wrong, but in my head I kind of think of these things sometimes like a difference between mechanism and process, right? So a mechanism has a kind of, like we were talking about with the vending machine. So actually going and buying something from a vending machine, that's like a complex process that has many different ways of doing things. But that one mechanism of having the coin and that machine is providing a mechanism that is repeatable and observable in itself and can give us maybe probabilistic inference, like it's highly probable that this coin is going to achieve this mechanism within this vending machine, which will open up the process? Or is that still coming down to, but the actual whole process requires lots and lots of dispositions happening at the same time, including the probabilistic nature of that mechanism? Would that be, or is that also too reductionist?
No, but I think it really shows the difference between the zooming in and zooming out, because if you keep focusing on the tiny mechanism, you do this and then this will happen. And you forget everything around that. Okay, you need to have something that has this and this. It should be valuable. It shouldn't be something fake. It should be. I mean, yeah. So if you keep focusing on this small mechanism here, you might forget everything else that was needed to even get here. Also, we all know how often these vending machines fail. So it's typical that when something fails, that we might zoom out to understand more. So this difference between zooming in and zooming out, I think that is really important in research, that we do both. Because sometimes, yes, sometimes it is by zooming in that you find a problem, but other times it's like, okay, how did we even get here?
Absolutely, yeah.
And that might be really useful.
Yeah, and that's a sort of a flexible clinical skill that perhaps we don't necessarily nurture at the moment, because we're nurturing this zooming in, I suppose, all the time. Well, what, and that's that tendency towards reductionism, isn't it? Where we just keep going deeper and deeper, finding that one, and splitting the atom, and then splitting what's in the split atom, and all of that, which is useful and important. But we also have to remember that that exists in a context that is unique to that individual, and so we can't just keep applying these highly reduced laws or rules to everybody.
Yeah, but even, I mean, sometimes it is there in the tiny thing, but it might be the wider context that tells you how it got there.
Yeah,
I mean, so it doesn't mean that it cannot possibly be that in the little atom, but it just means that you have the person in front of you that might be able to tell you what gets you to that stage. So I've been watching a TV series which is not very realistic, the New Amsterdam in the hospital series in Netflix, and there is a guy who is very good at diagnosing. And at some point, the hospital new boss, they standardize and they say, okay, no one uses more than 10 minutes before they diagnose someone from the ER. And he keeps taking all the others 10 minutes. So they give him their 10 minutes because he spends the whole day. But then when he's finished, he knows exactly what's wrong with them. And it's something that, okay, so he could have given a very quick diagnosis and they would go straight to treatment, but it would be wrong. So then they would have to come back and get a new diagnosis straight to treatment. It would be wrong. So instead of doing that, he wants to get it right. And I just think, well, isn't that very typical of the way healthcare is organized today? It's supposed to be time and cost efficient. And we keep giving people hasty diagnosis, hasty treatments, and then they go away and at best they are not helped. At worst, they are harmed. So I just think, what's wrong with taking an hour and getting it right, or taking 5 hours and getting it right instead of having people chronically ill in the healthcare system? I just think that's appalling.
Or even if the condition is chronic and likely to be chronic, then, or long term, then having appropriate services that are flexible to that as well. Because I sometimes wonder whether the clinicians sometimes feel like, well, if we just find the right solution, if we just have more time, if we can find the right thing, then we can prevent chronicity, especially with pain. I'm not sure that is exactly what we're saying here, but it's like, it's being able to create a flexible system that is appropriate to the individual, which I think at the moment we don't have because of lots of systemic problems as well. And I think that you're completely right. We need to be able to say, well, this individual, we need more information and we need to be able to explore more, or we need to change how we deliver treatment for this person and how it looks for this individual. And especially in MSK practice, where we're becoming more and more rigid in time, particularly, because time is really the commodity, isn't it? It's not anything else. It's how much time we get with someone, and that's almost like the coin in the vending machine. That's one of the things that we don't seem to have much flexibility around in our system, and but if we could create a system where we can be sort of flexible and responsive to the individual based on all of our acknowledging and observing and listening and hearing all of the dispositions, then we would have a better healthcare system. That's what we're doing it for, I guess. Okay, yeah, I'm gonna shut up.
Thanks, Rani. It's a privilege listening from you, because I did struggle whilst I was reading the chapter, but what you discussed today made a lot of sense. I just wanted to ask a few questions from almost like practical implication side. Why is it that we should learn about philosophy, or how does philosophy, how is it relevant to my practice?
Well, it is relevant if because all of the practice is based in some philosophical assumption, for instance, about, I mean, if we think philosophically that we can only trust what we can observe. I mean, that's an empiricist starting point. But if you're in a discipline where this is just taken for granted, then you as a practitioner, you're never allowed to challenge that. And the same thing if you think that, well, you need to have same cause, same effect over the same conditions. And then as a clinician, you say, well, all my patients are different. And the people writing the guidelines say, well, but at least they're sufficiently similar. I mean, you are not in a position to challenge it. So what we want to do, we want to empower clinicians with some philosophy that they can use to take part of the debate of the paradigm that you work within. Because I really think this evidence-based paradigm, it was not introduced by clinicians. But I mean, it can be overthrown by clinicians. That's why we call it the clinical revolution. And the same with reductionism. I mean, yeah, so reductionism is an assumption that is easy to hold if you work in the lab. But it's not easy to hold if you work in the clinic. So I think that these clinical experiences and the clinical knowledge, it should feed back to research. It shouldn't just be that clinician sits there and juggle research and try to make it work for their patient. It should come back and say, no, but this doesn't work, not for these types of people. It doesn't work here, it doesn't work here. You figure out why. And then they should put people to figure out why.
That makes sense. I think what this is doing is perhaps it's offering me that flexibility, and it's helping me think slightly differently. I may not have the answers, and it's allowing me to accept different perspectives. And it's perhaps not putting that much pressure on me to know things. It's inviting me to ask the person who knows a lot about themselves to tell me what is it that they think, or explore what their understanding is. So my next question is, because you've mentioned causal evidence comes from the patient, how do we get better as clinicians in our limited clinic time that we have? How do we get better at listening and understanding to that person's narrative?
So we have at least 2 people who work specifically with this in the project, and they have written the last 2 chapters of the book, Brian Broom and Anna-Louise Kirkengen. So they are very concerned with these patient narratives and how to work with that. And I mean, one thing that Anna-Louise Kirkengen, she has worked a lot with childhood trauma. She also has worked with, in the chapter, she writes about working with the physiotherapist. But yeah, so she said, for instance, when she's looking at someone's really thick file of their whole medical history and all the case reports that they have, she would say, well, it seems to me that something is missing here in your story, because it doesn't say anything about why you got ill or what happened to you when you were 14, when you were first put in the mental health care for trying to kill yourself, for instance. And people might explain why. And it might explain everything else that has happened to them. And then the problem is that if they have not been diagnosed properly, or they have not been understood properly, they have been given surgery and pills and various treatments where no one has ever targeted the core problem. And Kai Brynjar Hagen also, he works with people with morbid obesity, and he talks to them before they're going in to operate away half their stomach. And sometimes he says, this person should not have surgery. I mean, they used to have anorexia, eating too much. This is not the problem. They have other reasons why. They have mental pain. They have problems. They need help in the system. They don't need surgery. And he's really concerned with how people are mistreated in the system because they are not listened to. And he also says that a lot of his colleagues, I mean, this is something that Brian Broom also says, a lot of their colleagues are very uncomfortable asking people what actually happened and what they think is actually the problem and listening to it, because they say, I'm not a therapist. I'm not trained as a therapist. What if they get traumatized again by telling me these things? What can I do about it? And one thing that Anna-Louise Kirkengen says is that, well, sometimes this is the first time they tell anyone. And just getting the feedback that this is not an okay thing that happened to you and it's a healthy reaction. It's not you who are unhealthy. It's a healthy reaction to something that is really traumatizing. And no one can get through life without being affected by something like this. And Brian Broom also says, he talked to people where they think they're dying from a heart condition or something, and it's just major stress because of their life situation, which is perfectly understandable that they would have this massive reaction to it. So I think a lot of people, they don't want to ask, and some people have said, well, I understood that there was something there, but I didn't want to ask because I don't know what to do with it. But even being that first stage where they get someone who understands and someone who is willing to listen to it and someone who is able to say, there might be a link between your condition now and what you experienced. It might be a link with your stress. It might be a link with this and this. Maybe it's not. But yeah, I also heard people who said that they keep getting the wrong treatment because it's what's supposed to work best. So Christina Price, for instance, who wrote in the second part, she said she always gets the best available treatment, but it keeps harming her. And when she says it harms me, she's not listened to. So, I mean, so it doesn't have to mean that everyone has mental trauma or abuse in their childhood, but they might be physically hurt by the treatment. And that's the same with the side effects. So I just think, well, one should be allowed to give the person in front more credit for actually knowing about causally relevant information about their own body and their own experience.
Agreed.
Thank you.
Yeah, absolutely. Thank you so much. I think we're going to bring this to a close now, but that was a fantastic discussion. Thank you so much. And I can't wait to share this with the community, actually. I just want to let's get off the call so we can get it up and loaded and see what people say. Because I think that this conversation will help bring together a lot of the themes that we've been looking at over the year and give people a framework to map that onto. Looking at, different ways of thinking about, pain from different perspectives and that sort of philosophizing skill within clinical practice, which I think we have undervalued for a while.
Yeah, so, I mean, because it's not that once you introduce dispositions, there is a quick fix. I mean, actually what we're saying, it's so much more complicated. We cannot believe that there is a quick fix that can be done with statistics. We cannot think that generating more data, just looking at A and B is going to tell us everything we need to know. We need to know so much more. And as a community, this is something that is happening from many different professions and different types of research. So what Anna-Louise Kirkengen has been pushing now for years and years, now there's so much research to back it up. But there wasn't before because it wasn't accepted that something like trauma could ever make you biologically ill.
Yeah, absolutely. Fantastic. So thank you very much to Rani, of course, and as always for sharing your knowledge and information with us. And thank you so much to Christine and Nikita for being here. And thank you everybody that takes the time and invests in their clinical practice by watching this video, and good luck integrating it, and keep in touch with us over the process of how you start integrating it. I know that we all love to hear that, and especially the chaps over at the Cause Health Project, they love hearing from clinicians who are thinking about this on the shop floor and how this can change our practice and support improved delivery of healthcare. So wonderful. All that's left to say is ta-ra, and I'm sure we'll see you again, Rani. We'll be bringing you in again, and the rest of the team, I'm sure. Thank you very much, everybody.
Thank you for inviting me, and thank you for reading the chapter.
Of course.
Oh yeah, and that is just to say that you can download the entire book for free from the Cause Health website. We will put all of those links on there. There's also other resources and other communication partners that are supporting the spreading of the Cause Health message through podcasts, courses, chapters, books, lots of other different ways as well. And we'll put all of those links up for you there too. So yeah, till next time. Thank you very much. Bye.
Bye.
Bye-bye.